Colleagues and friends, I'm delighted to welcome all of you to our Surgical Thursdays. Today is 27th of January 2022, and we are starting a new course, a series of lectures, again in partnership between Alliance for Global Clinical Training and Netcare Foundation in Tanzania. We are starting a new series after a couple of lectures, around 10, 12 lectures on vascular surgery for general surgeons. It was wonderful having Dr. Bill Schechter, who is a professor from the University of San Francisco in California, United States of America. He is also leading us into the new series that we are starting today. Our new series today we'll have a lecture to introduce us to the basic concepts, and then we'll have a follow-up lectures in the couple of the days that are about to come, whereby we'll be pondering into many subjects within the field of hand surgery. With all due respect, remain muted the entire time of presentation, and if you have questions, you can unmute, or you can write on the chat box and I can fall through there. Dr. Bill Schechter will present to us for 40 minutes to 50 minutes, and the rest of 20, 30 minutes, 30 to 40 minutes will be used for discussion. The floor is yours, Prof, and everyone remain muted. You're welcome.
Okay, can everybody see the slides?
Yes, we can.
Okay, great. Okay, so good evening, ladies and gentlemen, and thank you for attending. What we're going to do this morning is I'm going to give you an introduction to this series of lectures. Please mute your microphones. Thank you. I'm going to give you an introduction to the series of lectures, and we're going to start off with hand anatomy. And just to put this series of lectures in context, if you, those of you who've been with us all along, you recall that we've had courses on trauma care, perioperative care, surgical intensive care, and those courses primarily focused on physiology. And then we just finished a course on vascular surgery for general surgeons, and that course combined physiology, but a lot of anatomy. And in this course for hand surgery, we're going to deal a little bit with the physiology of the hand, but we're going to be focused primarily on clinical anatomy. And so that's just to put in perspective what we're doing. So the obvious question is, if you're a general surgeon, why should we even be studying hand surgery? So we're going to deal with that question. We'll talk about the goals of the course. We'll give you a course outline, and that'll finish the introduction. And then we're going to we'll get into the meat of the subject, which is hand anatomy. So, why study hand surgery? Well, the hand is the most common bodily part injured. So if you're talking about an emergency room, at least in the United States, I don't know what the situation is in Africa, but about 40% of the people who show up in emergency rooms have some problem related to the hand. And hand injuries have devastating long-term social and economic consequences. And the optimal treatment for hand surgery is time sensitive. You have to do it right the first time, because if you don't do it right the first time, all the efforts to fix it later on may help, but it's never going to be as good as if you did it as you fixed it correctly the first time. And the last point is, not all hand injuries, but almost all hand injuries can be competently managed by general surgeons who have been trained in the principles of hand surgery. So what we're trying to do with this series of lectures is bring everybody up to a certain level of knowledge and competence in hand surgery problems, focusing primarily on injuries. We will be talking a little bit.
Recording in progress.
We will be talking a little bit about hand injuries later on, in, at the end of the lecture series. Or sorry, hand tumors. Sorry. Now, it's even more important to study hand surgery for surgeons working in low and middle income countries, because the broadly trained general surgeon is essential to provide the care for the broad spectrum of diseases, including injuries of the hand, because if you're working in a district hospital, you may not have access to subspecialty surgeons. So I hope that this course will provide you with the information to perform this task with confidence and competence. I just want to give you a warning before we start, and that is the hand has a lot of anatomy packed into a very small space. So these lectures on hand surgery contain a lot of information, and I advise you to take notes during lectures, because it's easy to forget this stuff. It goes in one ear and out the other. And the other thing is, most of the hand anatomy lectures are going to employ extensive use of videos. And so if you want to stop the video, I may stop the videos to make some comments on, but if you have questions, just put them in the chat box, and Mugisha will let me know, and we can halt the video and deal with the questions in real time. Alternatively, we can spend some time at the end. But as I said, I advise you to take notes, because this is there's a lot of complicated stuff going to hit you very rapidly. All right. Why is it not advancing? Okay, so at the end of this course, you should have an in-depth knowledge of the anatomy of the hand. I hope that you will achieve an organized approach to the evaluation and initial treatment of hand injuries and diseases, including severe infections of the hand. You'll have an understanding of the complexity of the flexor and extensor tendon mechanisms and their repair, and you'll have a basic understanding of the repair of injured nerves and an ability to repair severed peripheral nerves. And then, as I said, after we finish all of that, we'll put all these concepts together, and then we'll discuss the approach to the mangled extremity, and also we'll talk about hand tumors, because in my time in Africa, I've faced a fair number of sarcomas of the hand. So and usually the knee-jerk approach is to cut the limb off, but often you do not need to do an amputation for a hand tumor, and we'll discuss some cases where we didn't do that. So this is the outline for when we have giving the course in person. But you'll see that we have the first two lectures after the introduction are all upper extremity anatomy, and sometimes this can get a little old, but you have to really understand the anatomy of the upper extremity very well in order to get into the appropriate treatment later on in the course. So we're going to have after the anatomy, we're going to have a lecture on evaluation of the injured extremity, how you initially treat injured upper extremities. We'll talk extensively about hand infections. Then we'll talk about flexor tendon injuries, extensor tendon injuries, nerve injuries, compartment syndromes, and then the soft tissue coverage of the hand. In other words, when you have an injury where you lost a lot of soft tissue, what are the options for covering that wound? And then we'll talk about the mangled extremity and hand tumors. Okay. All right, so that finishes our introduction. Any questions or comments on the introduction? Okay. Okay, Mugisha, can you see the slides?
Yes, I can see.
Okay, great. All right, so we're going to start with two videos on the upper extremity anatomy, and these videos. There's actually a series of 3 videos. We probably won't get to the third video till next week, but the reason I have 3 videos, they go from a more simplified approach to the anatomy of the hand. The second one gives you goes over the same material in more detail, and then we might get to the third one or part of the third one today. We certainly won't get to all of it, or we might just end at 2 videos and then review the material. And if you guys are up to it, I can ask you questions about the as a review to if you're open to that. And then the third video, we're very lucky because I found on the internet a old movie picture of hand anatomy in a cadaver. In other words, what we're going to see now was our cartoons, but hand anatomy of in a cadaver by Bob Chase, who is probably the greatest hand anatomist of the 20th century. And he made this movie in the 1960s when he was a young man at Yale University. He subsequently moved to Stanford University and was I think, recognized as the premier hand anatomist in the world. So I just happened to find this on the internet. So we're very fortunate, but it is very, very complicated. So it's good to have these more simplified videos first. All right, so having said that, here we go with the first video.
Structures of the human anatomy are as unique as the hand. The hand needs to be mobile in order to position the fingers and thumb. The hand must have adequate strength to grip objects firmly, but must also.
Mugisha, that's the loudest I can make it. I hope you guys can hear that. Can you hear it?
We can hear.
Okay, good. Let's continue.
So be coordinated to perform fine motor tasks. Important structures of the hand divided into several categories. These include bone, joints, ligaments, tendons, muscles, nerves, blood vessels. Let's define some common anatomic terms as they relate to the hand. This will make it clearer as we talk about the structure of the hand later. The front or palm side of the hand is referred to as the palmar side. The back of the hand is called the dorsal side. The half of the hand from the middle finger to the thumb is called the radial side. The other half is called the ulnar side. There are 27 bones within the wrist and hand. The wrist itself contains 8 small bones called carpals. Carpals join with the 2 forearm bones, radius and ulna, forming the wrist joint. Further into the palm, carpals connect to the metacarpals. There are 5 metacarpals forming the palm of the hand. 1 metacarpal connects to each finger and thumb. Small bone shafts called phalanges line up to form each finger and thumb. The main knuckle joints are formed by the connections of the phalanges to the metacarpals. These joints are called the metacarpal phalanges joints, or MCP joints. The MCP joints work like a hinge when you bend and straighten your fingers and thumb. The three phalanges in each finger are separated by two joints called interphalangeal joints or IP joints. The one closest to the MCP joint is called the proximal IP joint or the PIP joint. The joint near the end of the finger is called the distal IP joint or DIP joint. The thumb only has one IP joint between the two thumb phalanges. The IP joints of the digits also work like hinges when you bend and straighten your fingers and thumb. The joints of the hand, fingers, and thumb are covered on the ends with articular cartilage. This white shiny material has a rubbery consistency. The function of articular cartilage is to absorb shock and provide an extremely smooth surface to facilitate motion. There's articular cartilage essentially everywhere two bony surfaces move against one another or articulate. Ligaments are tough bands of tissue that connect bones together. Two important structures called collateral ligaments are found on either side of each finger and thumb joint. The function of the collateral ligaments is to prevent abnormal sideways bending of each joint. In the PIP joint, the middle joint between the main knuckle and the DIP joint, the strongest ligament is the volar plate. This ligament connects the proximal phalanx to the middle phalanx on the palmar side of the joint. The ligament tightens as the joint is straightened and keeps the PIP joint from bending back too far or hyperextending. Finger deformities can occur when the volar plate loosens from disease or injury. Many of the muscles that control the hand start at the elbow or forearm. They run down the forearm and cross the wrist and hand. Some control only the bending or straightening of the wrist. Others influence motion of the fingers or thumb. Many of these muscles help position and hold the wrist and hand while the thumb and fingers grip or perform fine motor actions. Most of the small muscles that work the thumb and little finger start on the carpal bones. The bulge of muscle at the base of the thumb in the palm is called the thenar eminence. The bulge of muscle at the base of the little finger is called the hypothenar eminence. Four muscles make up the thenar eminence: the abductor pollicis brevis, flexor pollicis brevis, adductor pollicis, and opponens pollicis. Pollicis is the Latin term for thumb. Each of these muscles begins at the wrist, and each has a tendon that attaches to a different location on the base of the proximal phalanx of the thumb. Their names give a suggestion of what they do when they contract. The abductor pollicis brevis abducts or moves the thumb away from the midline of the hand. The flexor pollicis brevis flexes or bends the thumb. The adductor pollicis adducts or moves the thumb towards the midline of the hand. The opponens pollicis moves the thumb.
Just a point here, that adductor pollicis muscle that you just saw is innervated by the ulnar nerve and is a key component of power pinch. So that when you get you'll learn later on that when you get an ulnar nerve injury, the patient will have the inability to pinch a piece of paper, and it's due to the paralysis of the adductor pollicis muscle, which you just saw, and the first dorsal interosseous muscle, which abducts the finger, which you'll see in a moment. I just thought I would point that out while we're here.
Opposition pulls the thumb out from the palm, turns the palm of the thumb. This is the motion that allows you to place the thumb. Muscles of the hypothenar.
Okay, so this is a key point with median nerve injury. The muscles of the thenar eminence are all median nerve innervated. And in order to oppose the thumb, you have to be able to pull the thumb out of the plane of the hand like this, and then bring it apart. And that's basically the function of the thenar eminence, primarily the opponens pollicis muscle. So that when you get a median nerve injury, you lose the ability to oppose the thumb. And of course, the that is one of the key the key aspects of being human, is that we have an opposable thumb, which allows us to do fine motor work and grasp things easily. When you have an ulnar nerve injury, you'll learn more. We'll talk about that more later. But in terms of the intrinsic muscles of the hand, you have paralysis of the adductor pollicis muscle and the first dorsal interosseous, which we'll see in a moment, and that gives you and with that you lose the ability to have power pinch. All right, let's keep going.
Are arranged to function roughly the same. The smallest muscles that originate in the wrist and hand are called the intrinsic. Intrinsic muscles guide the fine motions of the fingers by getting the fingers positioned and holding them steady during hand activities. The tendons that allow each finger joint to straighten are called the extensor tendons. The extensor tendons of the fingers begin as muscles that arise from the backside of the forearm bones. These muscles travel towards the hand, where they eventually connect to the extensor tendons before crossing over the back of the wrist joint. As they travel into the fingers, the extensor tendons become the extensor hood. The extensor hood flattens out to cover the top of the finger and sends out branches on each side that connect to the bones in the middle and end of the finger. The place where the extensor tendon attaches to the middle phalanx is called the central slip. When the extensor muscles contract, they tug on the extensor tendon and straighten the fingers. Problems occur when the central slip is damaged. This can happen with tear. The flexor tendons allow the fingers and thumb to flip.
Okay, we're going to go over this and the anatomy of the extensor tendons again and again, particularly when we talk about extensor tendon injuries. But what you just saw there with the laceration of the central slip is you saw the PIP joint herniate up through what are called the lateral bands, the sides of that extensor tendon mechanism, and you basically get a flexed PIP joint and a hyperexpanded DIP joint, and that's called a boutonniere deformity. Boutonniere in French means a buttonhole, and so the people who described it thought that the PIP joint herniating up through the extensor mechanism sort of looked like a button coming through a buttonhole. We'll talk more about that later. I just thought if you want me to keep Mugisha, are these little comments during the video helpful, or should I just keep quiet?
Oh, they're very useful, I think.
Okay, so I'll just make comments at the appropriate time.
Strong flexor muscles in the forearm. Before they enter the wrist, flexor muscles form the flexor. Flexor tendons travel to carpal bone, palm, and two tendons each travel into the molar side. These two tendons, the flexor superficialis and flexor profundus, travel through a special tunnel formed by a series of specialized ligaments that form Pollicis. Flexor superficialis connects to the base of the middle phalanx. Flexor profundus tendon connects to the base of the distal phalanx.
Now these fascial tunnels are critical for flexor tendon function because they prevent bowstringing of the tendons. So if you have a bowstring tendon, you won't be able to flex the fingers efficiently because the tendon is not going to stay against the in intimate relationship to the digit, the bone of the digit. And so when as you will learn when we get to talk about flexor tendon injuries, you have to preserve this this fascial tunnel, and you have to retrieve and pull the cut tendon, which often retracts down into the palm or even sometimes into the wrist. You have to retrieve it and pull it up through through this myofascial tunnel and to repair it. And then there are various techniques that we will learn about how to do that. But if you don't do that and you repair it outside of the tunnel, you'll have a very inefficiently functioning finger. Now, these injuries that occur in this fascial tunnel are called zone 2 flexor tendon injuries, but we'll learn more about that later.
Thumb is a bit different. It only has flexor pollicis longus in the forearm, next to the base of the phalanx. Flexor pollicis brevis muscle begins in the wrist, next to the base of the proximal phalanx. All of the nerves that travel to the hand and fingers begin together at the shoulder. Radial nerve, median nerve, and the ulnar nerve. These nerves carry signals from the brain to the muscles that move the arm, hand, fingers, and thumb. The nerves also carry signals back to the brain about sensations such as touch, pain, and temperature. The radial nerve runs along the thumb side edge of the forearm. It wraps around the end of the radius bone toward the back of the hand. It gives sensation to the back of the hand, from the thumb to the thumb.
Now, this superficial radial nerve here, it's important to be aware of the anatomy of this nerve, because when you're operating in this area for another reason, if you injure that nerve, you'll lose sensation on the back of the hand, which is not a catastrophe, but it's an annoyance. But what can happen is that you get a neuroma as the nerve tries to repair itself, and we'll talk more about neuromas when we get to nerve injuries. But the patient will have electrical spasms every time they move the hand or hit it, which basically can incapacitate a person. So this seems like a small point, the anatomy of the radial nerve as it goes to the back of the hand to innervate the back of the hand, and the radial digits up to the PIP joints, sort of over here in the back of the thumb. But if you injure that nerve when you're doing something else, you can actually incapacitate the hand. So you need to be aware of that.
It also supplies the back of the thumb, just beyond the main knuckle, back surface. Median nerve travels through a tunnel within the wrist called the carpal. The nerve gives sensation to the thumb, index finger, long finger, and half of the ring. It also sends the nerve branch to control the arm muscles of the thumb. The arm muscles help move the thumb and let you touch the pad of your thumb to the tips of each finger on the same hand, a motion called opposition. The ulnar nerve travels through a separate tunnel called Guillaume's canal. This tunnel is formed by two carpal bones, pisiform and hamate, and the ligament that connects them. After passing through the canal, the ulnar nerve branches out to supply feeling to the little finger and half the ring. Branches of this nerve also supply the small muscles in the palm and the muscle that pulls the thumb toward the palm. Each finger has a pair of sensory nerves, one on each side, that runs to the tip of the finger. These nerves are called the digital nerves and supply sensation to the fingers. Traveling along with the nerves are the large vessels that supply the hand with blood. The largest artery is the radial, that travels across the front of the wrist, closest to the thumb. The radial artery is where the pulse is taken in the wrist. The ulnar artery runs next to the ulnar nerve through Guillaume's canal, which has been mentioned earlier. The ulnar and radial arteries arch together within the palm of the hand, supplying the front of the hand, fingers, and thumb. Other arteries travel across the back of the wrist to supply the back of the hand, fingers, and thumb.
Very occasionally, you'll be dealing with a cut at the base of the hand, which injures the ulnar nerve, either just proximal to Guillaume's canal or even in Guillaume's canal. So sometimes you'll have to open up Guillaume's canal in order to fix the ulnar nerve. We'll talk about that when we get to ulnar nerve injuries, but I just want to, but these seemingly small points, which he's going over very rapidly, can be very important in terms of the clinical care of the patient. So what you'll find throughout this course is we're going to be repeating this anatomy over and over again as we deal with specific clinical problems. So as I said, there's a lot of information being presented in a short period of time. Try to take notes and think about it, but you will see this information again and again during the course of this course.
Our hands are free of problems. Take complex anatomy. The hand is formed by numerous structures, which has an important role in normal hand function. Greatly impacts whether the hand functions.
Okay, so that was a simplified view of hand anatomy to give you an introduction. And now we will go in, look at a video that gives you a more in-depth discussion of the same information that we just saw. And let's see if this is it. No, this I'm going to stop this. This is the very complicated one that either will be for later this week or later to the spring or probably next week. And let's see why it is that I can't find this other thing here. Oh, that's why, because it's here it is. Okay, I got it.
Structures of the human anatomy.
I'm sorry about this, guys. I'm just getting confused here. All right, here we go. Sorry, I'm a little dense here this morning. Okay, we got it. Here we go.
Hello, in this video, we're going to look at the clinical anatomy of the hand and also the fingers. So we'll actually focus on the wrist joint mainly. Now, we'll begin by focusing on the right hand. And here's the right hand, looking at it from a palmar view, the palms of your hands. And actually, the surface anatomy here, you can actually feel your scaphoid bone, the tubercle of your scaphoid bone. And there's also the piriformis bone you feel, as well as above it, the hook of hamate somewhere. Let's look at the right hand again and introduce some of the bones now. Here are the forearm bones, the ulna medially and the radius laterally. You can remember the radius is lateral because lateral is where you feel the radial artery. The wrist bones consists of many small bones. To put it simply, there are 8. 4 sitting on the top and 4 below. They are collectively known as the carpal bones. You can remember the 8 carpal bones by starting at the thumb and moving around in a clockwise motion. And remember this saying, so long to pinky, here comes the thumb. So S is for scaphoid, L for lunate, T for triquetrum, P for pisiform. Moving up, H is for hamate, C for capitate, and then trapezoid, and then trapezium.
Okay, so if you're not focusing on orthopedic hand surgery, you can get fractures of the scaphoid, and we're going to have a lecture on hand fractures later on in the course. But I spent my career taking care of a lot of hand injuries without being an expert on the carpal bones. There's, as you can see, there's a lot of them with weird names. And you may have learned this so long to pinky, hello to thumb expression when you were in medical school. I didn't. So I'm giving you guys a chance to write this down because it's a fantastic way to remember. S, so long, so scaphoid, long, lunate, triquetrum to pinky, pisiform. And then, so that's going from radial to ulnar, and then that's the base. And then ulnar to radial, it's hamate, capitate, trapezium, thumb, and I've already forgot it's hello something to thumb. So if you can remember this this expression, that'll help you remember the names and the order of the bones. So you're going radial to ulnar for the bottom set, ulnar to radial for the top set. All right, let's continue.
So again, so long to pinky, here comes the thumb. The bones of the hands are made up of metacarpal. Then you have the phalanges, and then you have of course, the distal, middle, and proximal phalanges, which are the fingers essentially. Now remember, the thumb has a metacarpal, but it has a proximal and then a distal phalange. So there's no middle phalange. Drawing the same right-hand diagram again, looking at it from a palmar view, and imagine cutting a slice through these two sections at the carpal bone. So again, we are basically looking at the 4 carpal bones at the top, or the distal 4, and then the other proximal 4 carpal bones. So focusing on the distal 4 carpal bones from the pinky, here comes the thumb. So H is for hamate, C for capitate, T for trapezoid, and then trapezium. Trapezoid and trapezium might be confusing because they sound similar, but to remember which one comes first, think of the last letter of each word. So the D is before the M, and so
this is an important way to learn the order of the trapezoid and the trapezium, because they both start with a T. So you get to learn the order. The trapezoid ends with a D, and trapezium ends with an M. D comes before M in the alphabet, so you know that the trapezoid comes before the trapezium.
Trapezoid is first, and then it's trapezium, which is closest to the thumb. The hamate has a hook, and traveling across the hamate and the trapezium is the flexor retinaculum. The flexor retinaculum is a very important structure to remember. But first, let's look at the other proximal 4 carpal bones. So long to pinky. S is for scaphoid, L for lunate, T triquetrum, and P pisiform. The scaphoid has a tubercle that can be felt. And here again is the flexor retinaculum. The flexor retinaculum is an important part of the hand's anatomy, the wrist anatomy, because things run over it and things run under it. So let's have a closer look, and let's stick with the right hand for now. But before going on, I want to introduce to you a tendon that runs over your flexor retinaculum, called the tendon of Palmarus longus. This tendon is a big tendon you can see in the middle of your wrist. And this tendon, it originates essentially from the medial epicondyle and is responsible for flexing the wrist. It is innervated by the median nerve. So here I'm drawing the carpal bones of the right hand. Let us now look at things that run superficial to the flexor retinaculum and things that run deep to the flexor retinaculum. Let's begin by looking at the deep structures. And there are many structures that run deep to the flexor retinaculum. It's easy to divide it into 4 things. 1, the median nerve. 2, the the tendons of Flexor Digitorum superficialis. 3, the tendons of Flexor Digitorum profundus. And the 4th is the tendon of Flexor Pollicis, Longus, which goes to the thumb. And the Flexor Digitorum superficialis and Flexor Digitorum profundus has 4 actual tendons.
It's going to stop here for a minute and talk about the importance of understanding this anatomy, particularly with injuries to the palm of the hand or volar surface of the forearm, because you can see that the median nerve is right underneath the Flexor Retinaculum, and then there are 9 tendons, the 4 superficialis, the 4 profundus tendons, and the FPL, the Flexor Pollicis Longus tendon. And so if you have what's called a zone 4 injury, we're going to learn more about that later, but if you have an injury underneath the Flexor Retinaculum, you've got to divide the Flexor Retinaculum in order to expose the injury. And often with a distal zone 5 injury, that is a laceration on the volar surface right at the base of the hand, you may need to divide the Flexor Retinaculum in order to find the distal ends of the tendon, which may have retracted up into the palm. And you sometimes you can retrieve them by flexing the fingers, but sometimes you have to divide this tendon. The other thing is you're all familiar with the carpal tunnel syndrome, which is basically swelling that occurs in this tunnel, the carpal tunnel, deep to the Flexor Retinaculum, and you can get the injury or compression of the median nerve, which causes paresthesias and sometimes decreased sensation, and even in advanced cases, muscle atrophy of the thenar eminence, which is innervated by the median nerve. And the treatment is to decompress the carpal tunnel by dividing the transverse carpal ligament. But you have to be careful when you do that, because you can transect the median nerve in the process of doing this, and then of course you have a ruined hand. So you've got to know this anatomy. You've got to identify the median nerve and protect it whenever you divide the transverse carpal ligament. All right, enough said about that. Let's keep going.
I actually drew this wrong. The tendon of Flexor Pollicis Longus should be at the right-hand side because that's the side of the thumb. Sorry. Anyways, let's now look and talk about the structures which run superficial to the Flexor Retinaculum. I just want to add the hook of hamate here and the trapezium here. Again, these are the distal carpal bones. Okay, so the structures that run superficial to the Flexor Retinaculum include the tendon of Palmarus longus, which I talked about. Because we are looking at the right hand, the ulnar structures are on the left side, medially. So here is the ulnar artery and the ulnar nerve. Palmar cutaneous branch of the ulnar nerve and the palmar cutaneous branch of the median nerve can also be found on the other side. Okay, some clinical relevance of the Flexor Retinaculum and the median nerve. So here is the right hand again. Here is the Flexor Retinaculum. It's also sometimes referred to as the carpal ligament, which makes sense because it literally goes over the carpal bones. Anyway, remember the 4 main groups of structures that run under it, one of which is the median nerve. The median nerve is sensory for the middle, index, and thumb region, and also motor for these regions as well. Carpal tunnel syndrome is where you get compression of the median nerve at the Flexor Retinaculum, causing numbness, paresthesia, and pain in the median nerve distribution. Carpal tunnel syndrome affects females more than men. And there are many causes that actually can cause carpal tunnel and irritate the median nerve. Going back to the diagram we drew earlier, do you remember the tendon of Palmarus longus? The tendon that goes over your flexor retinaculum, the tendon you can see on your wrist. Well, this tendon, it has some branches that come off it and form what's called the aponeurosis, the palmar aponeurosis. And this has some clinical relevance. Another clinical relevance is Dupuytren's contracture, which is localized thickening and contracture of the palmar aponeurosis. It causes the proximal and middle phalanx, or phalanges, to flex. The distal phalanx is unaffected. Let's look in more detail at the anatomy of the finger, the phalanges. So here we are mainly looking at either the middle, index, or pinky, or ring finger, but we're not looking at the thumb because the thumb does not have a middle phalanx. And these other fingers, they consist of the distal phalanx, the middle phalanx, and the proximal phalanx. And then you have your metacarpal. Now, remember the tendons that run under the flexor retinaculum? Well, this is where we talk about some of those tendons and where they attach on the finger. See, the flexor digitorum superficialis tendons run towards the proximal phalange, then bifurcates and attaches to the middle phalanx. And so we can say that the flexor digitorum superficialis tendon flexes the proximal interphalangeal joint. The flexor digitorum profundus tendon.
This is important anatomy because we're going to be using this when we talk about evaluation of the hand and hand injuries. We're going to be looking at the flexion of the distal phalangeal joint, the proximal phalangeal joint, and the MCP joints, the metacarpal phalangeal joints. So this anatomy is very, very relevant to your hand examination.
Run below, deep the flexor digitorum superficialis and attaches to the distal phalanx. It does not bifurcate. Thus, we can say the flexor digitorum profundus tendon flexes the distal interphalangeal joint. All right. Some clinical anatomy. Trigger finger is a condition where there is localized thickening of long flexor tendons, which then prevent movement of the tendon within the fibrous sheath. So just think about it as part of the flexor tendon thickening, creating a lump which prevents movement of the finger. So let's just draw it out.
Think of a finger trigger like the eye of a needle. And let's say you're pulling a thread through the eye of the needle, and it moves very easily. It glides through the eye of the needle. Then put a knot in the thread, and now try to pull the thread through the eye of the needle. You'll feel that you can't do it, and then as you pull hard, it'll pop through. That's what a trigger finger is, because it's trying to move through that fibroosseous fascial tunnel that we talked about with zone 2 flexor injury. So you have a swelling of the tendon, which is like the knot on a thread, and then you're trying to you say you flex the finger and you're trying to extend your finger and you can't do it, and it hurts and then boom, suddenly there's a release and it pops through and slides. So that's what a trigger finger is. I've had that happen to me on a number of occasions in my life. Perhaps some of you experience the same thing.
Here is a finger, like your index finger. Here are your phalanges, and proximally is your metacarpal bone. Sorry, I know I wrote metatarsal. Tarsals are in your foot. This is meant to be metacarpal. Now, in this diagram, it's also important to know that you have these fibrous sheath sort of running on your palmar surface of your fingers. And these fibrous sheath, they sort of act as a pulley. And under it is the flexor tendon. The flexor tendon runs under the fibrous sheath. A trigger finger is essentially where you have sort of a nodule or thickening of the flexor tendon that runs under the fibrous sheath. And this causes a sort of restrictive movement of that finger. In this case, the flexor tendon thickening or nodule is occurring in between the metacarpal bone and the proximal phalanx. This inhibits the flexion between the metacarpal and proximal interphalangeal joint. Although in this video, we're going to look at the clinical anatomy of the hand and also the.
Okay, so that ends our two videos. So Mugisha, I'd like some input from you. Do we have a question and answer period now, or you want to watch part of the third video? We won't get through the whole thing today because it's long.
Yes, maybe we think through the. We have 30 minutes to time. We can do a third video and then we close.
Okay. All right, so let's look at the third video then. All right, so now we're going to see the same anatomy that you saw in the two videos with cartoons, but in much greater detail by a real by just a phenomenal clinical anatomist. But we're going to see him in cadavers now, so you're going to see what it actually looks like in the human extremity. So here we go. There we go. So this is a movie theater that was a movie on film that was digitalized. That I hope you'll be able to hear it. If you can't, let me know and I'll explain it. But we'll hopefully you'll be able. The volume will be loud enough for you to hear.
The functioning human hand is an intricate, complicated organ under a multiplicity of influences mediated through the contralateral cerebral cortex. A study of the functional anatomy is at best inadequate, but critically important in understanding some surgical principles in hand surgery. The palmar fascia consists of longitudinal, transverse, and vertical fibers. Superficial vertical fibers are intimately attached to the palmar skin, necessitating sharp dissection of the skin from the fascia. The longitudinal fibers take their origin from the Palmarus longus tendon. They extend in fan-shaped manner to the level of the middle phalange. The deep portion of the vertical fibers coalesce into septa, which extends downward to the level of the metacarpal, between the longitudinally oriented structures passing to the digit.
These are the digital nerves right here. You can see it.
In removing the palmar fascia contracture, the septa must be cut. The dorsal fascia, by contrast, is loose and areola, which accounts for the mobility of the dorsal skin and the frequency of avulsion injuries on the dorsum. The superficial extensors have a constant relationship as the extensor retinaculum. There are two tendons in the first compartment, the extensor pollicis.
Okay, so what he's going to show you now is this is the extensor retinaculum crossing the wrist joint. And there are 6 compartments through the extensor retinaculum. The first compartment contains the extensor digitorum, the extensor longus and brevis. The second compartment It contains the extensor digitorum brevis, and then you have the extensor pollicis longus here in the third compartment. The fourth has the extensor digitorum communis. The fifth compartment contains the extensor digiti quinti, which is an independent extensor of the fifth finger. And then you have the extensor carpi ulnaris in the sixth compartment. And I'm sorry, I misspoke. The first compartment contains the abductor, pollicis, longus, and brevis. The second is the extensor, the wrist extensor. They have a long and short wrist extensor. The third is the extensor pollicis longus. We're going to hear this again, but the reason I'm emphasizing this is when we're going to talk about extensor injuries on the back of the hand later on, you have to know this anatomy, because you can get cuts through the extensor retinaculum. You can get cuts just proximal and distal to the extensor retinaculum, and the tendons retract through these separate tunnels. So you have to know what the tunnels are, and then we have to be able to retrieve the tendons and then bring them back through the tunnel so that we don't get bowstringing on the back of the wrist, if we can possibly avoid it. So that's the that's the clinical significance of what he's talking about now.
Abductor pollicis longus. In the second compartment, there are two tendons: extensor carpi radialis longus and the extensor carpi radialis brevis. In its own compartment is the extensor pollicis longus, the most frequently injured of the extensor tendons. The tendons in the next compartment represent two muscle groups, the extensor digitorum communis and the extensor indicis proprius. The multiple tendons of the extensor digitorum communis primarily extend the metacarpal phalangeal joint. The index proprius allows independent extension of the index digit. In a single compartment is the extensor digiti minimi. Notice that it consists of two separate tendons. In the last compartment on the ulnar side is the extensor carpi ulnaris. All of these structures are radial nerve innervated. By unroofing the compartment, one can see the first two tendons, the abductor pollicis longus and the extensor pollicis brevis. The second two major wrist extensors, extensor carpi radialis longus and brevis. Standing alone, the extensor pollicis longus, then the extensor digitorum communis and a fellow traveler, index proprius. The digiti minimi proprius, and finally, the extensor carpi ulnaris. The investing fascia of the lower side of the forearm is an unyielding envelope. After its removal, one sees the superficial flexors. Starting from the radial side of the forearm, the pronator teres, the flexor carpi radialis, the palmaris longus, and finally the flexor carpi ulnaris. Just beneath the superficial group of flexors, one encounters the flexor digitorum superficialis. The flexor retinaculum at the wrist level is the roof of the carpal tunnel. The most superficial structure beneath the flexor retinaculum, the median nerve. Then, the Flexor digitorum superficialis. Most superficial, the central two digits. Just east of these, the superficialis tendon to the index and fifth digit.
We'll talk about this later on, but if you all take your hand and flex the third and fourth fingers and then put your index finger and fifth finger behind, this will help you remember the order of the tendons in terms of superficial to deep on the volar surface of the wrist. Tendons 3 and 4 are superficial to 2 and 5, and that's important if you're doing if you get a laceration across the volar wrist, and you get all these muscles and tendons there, and you're not sure which is which. You just flex your middle two fingers. You'll remember that 3 and 4 are superficial to 2 and 5, and that'll help you sort out which proximal and distal ends go to which. And of course, the distal ends of the tendon, if you just pull on the tendon, you'll see which finger is flexed at the PIP joint, and that'll tell you which superficial the flexor digitorum superficialis tendon is 2, 3, 4, or 5. Okay, let's keep going here.
One of the characteristics of the flexor digitorum superficialis is independence of function one digit to another. The superficialis tendon allows flexion of a single digit.
This is an important distinction between the profundus tendons and the superficialis tendons. Each superficialis tendon arrives from a separate muscle wad. So you get independent flexion of the superficialis. Actually, in my case, I cannot independently flex my fourth and fifth tendons because in about 15 to 20% of people, the superficialis tendons of 4 and 5 come from a single muscle wad. So most of the time, for most people, each tendon, superficialis tendon, has a separate muscle. Unfortunately, in me, that's not the case. So I'm never going to become a virtuoso guitarist because I can't, or violinist, because I can't independently flex my fifth finger. But that's in addition to having absolutely no talent whatsoever. But that's another story. Let's keep going.
Note that there is no flexion of the digit yet. Beneath the superficialis group, one finds the flexor digitorum profundus. Note the interdependence of the flexor digitorum profundus group of tendons. There is some independence of function in the profundus tendon to the index digit.
Oops. What happened? I'm sorry, I screwed up for a minute. We'll fix this in a minute, but I just wanted to make the point that when he's pulling on the profundus tendons, you're getting flexion of the DIP joints, but there's no independent function except many people have an independent flexor digitorum profundus tendon of the index finger. Now let's see if we can get back to where we were. I'm sorry, I messed up here.
Of the flexor digitorum profundus group of tendons. Some independence of function in the profundus tendon index digit. The last of the deep flexors is the flexor pollicis longus. The digital fibrous sheath starts at the level of the distal palmar crease and extends downward toward the digit tip over the flexor tendon.
Now this is a great picture because this shows you even better than the cartoons, the fibroosseous tunnel through which the flexor digitorum sublimis and profundus glide. So that if you get that cut within this fibroosseous tunnel and the tendon retracts back, you're going to have to go to the cut area of the sheath up here, and then put a little catheter down there, and then suture the tendon to the catheter, and then retrieve it up. And then we've got a prop. The reason injuries in this area were so difficult is that, of course, whenever you repair things, you get the wound heals by scarring, and if you get scarring attaching the repaired tendon to the fibroosseous tunnel, then the tendon's not going to glide and the finger is going to be frozen. So they used to call this area no man's land, because a guy named Sterling Bunnell, who was a pioneer hand surgeon in the 30s and 40s and even 50s, made a rule that you don't do primary tendon repairs in no man's land because many surgeons were opening up the tunnel and basically creating havoc. So he said, you don't repair that. You just close the injury and then send the patient to a specialist surgeon who will either do a delayed primary repair or do some type of reconstruction later on. And he felt the results were better. Now that there is a broader understanding of the anatomy and physiology, that we no longer do that, and we primarily repair tendon injuries in zone 2, but you have to be aware and do it very gently to try to avoid adhesions. And we'll talk about the exact techniques later on, but I just wanted to make that point because you can see that fibroosseous tunnel so beautifully in this picture.
An unyielding, tightly fitted structure, which accounts for difficulty in it with tendon repairs at this critical level. By removing the digital fibrous sheath, one can see the anatomical relationship of the flexor digitorum, profundus, and superficialis.
Now he's doing this for purposes of anatomic demonstration. Clinically, you would never do this. You always want to preserve this fibroosseous tunnel.
As one elevates the structures in the digit, you will see that the superficialis splits to allow passage of the profundus, the distal digit. Note the demonstration of the vinculi through which blood supply to the tendon is achieved.
I'm sorry. I want to make a point about those vinculi, because think of the vinculum. The vinculum is analogous to the mesentery of the intestines. Think of the vinculum like the mesentery of the intestines, so that the blood supply runs through it. And then what happens with the vinculum is if the vinculum is intact, the tendon will not retract into the palm, and you're lucky. Here we go. But often if you have a tendon injury at this location, the muscle is so strong that it will pull the tendon backwards and rip the vinculum, and then it'll retract into the palm or somewhere else.
One transects the superficialis at its insertion and attempts to reflect it out at the forearm. It forms a loop around the profundus and becomes impinged on the lumbrical. In order to successfully reflect the superficialis tendon at the wrist, one must split the tail of this tendon. The median nerve gains its entry into the forearm adjacent to the bicep tendon.
Very rarely, the tendon will retract into the wrist. Superficialis tendon or profundus tendon will retract. Usually, it's stuck at the level of the lumbricals or in mid palm. So, and you have to be aware of that. You know where to make your counter incision to retrieve the retracted tendon if it retracts proximal to your incision over the injury.
immediately penetrate and innervate the pronator caries. After passage through the pronator caries and the origin of the superficialis group, it lies on the deep side of the flexor digitorum superficialis through the middle third of the forearm. Just above the wrist, it courses around the radial side of the flexor digitorum superficialis to become the most superficial structure beneath the flexor retinaculum. It splits into multiple branches as it passes beneath the flexor retinaculum.
And I want to make a point here about the median nerve. If you're, we'll talk about this later, but if you're dealing with a laceration on the volar wrist, as you're exploring it, the first thing you have to identify is the median nerve for two reasons. First of all, you want to preserve the median nerve and you don't want to cut it in your dissection. The second thing is the median nerve is the key to wrist anatomy. There are two structures which are radial to the medial nerve. And that is the at the superficial level, it's the Flexor Carpi Radialis longus. Sorry, Flexor Carpi Radialis longus. What am I talking about? There are only one Flexor Carpi Radialis. The Flexor Carpi Radialis tendon and the radial artery. They are radial to the median nerve. Everything else in the wrist, all the flexor digitorum tendons, the profundus tendons, the flexor carpi ulnaris tendon, the ulnar artery, the ulnar nerve, they're all ulnar to the median nerve. The only thing at the deep level that's radial to the medial nerve is the flexor pollicis longus tendon. So you have, so radial to the medial nerve is the flexor carpi radialis, the radial artery, and deep, very deep, is the flexor pollicis longus. Everything else is ulnar to the median nerve. So if you're dealing with a laceration at this level that I'm showing you here at the proximal, at the distal wrist, and you're doing a wrist exploration, find the medial nerve and then examine all the structures, and you know what structures are there because you know the anatomy, and then you'll determine what, if anything, is injured and what to do about it. Okay, let's keep going.
It lies in relationship to the superficial vascular arch, which comes primarily from the ulnar artery, but has a superficial branch from the radial artery. It gives blood supply to the fingers through the common volar digital artery. Just beneath the superficial vascular arch, one may see the median nerve as it arborizes, here giving off a tiny recurrent motor branches to the median innervated thenar muscle, and its only other two motor branches, which extend to lumbricals number 1 to the index digit, and number 2 to the third digit.
Okay, this is another important clinical point. If you get a laceration over the thenar eminence, the recurrent median nerve, which innervates the thenar musculature, is at risk, and you have to explore that, identify it, and make sure it's intact. And if it's cut, fix it, because otherwise you're going to get atrophy of the thumb, and you'll have a intrinsic minus thumb. an old name is a simian thumb. In other words, a thumb like a monkey, because the great apes cannot oppose their thumb. We don't use the term simian thumb anymore because it has a pejorative element to it. So we use intrinsic minus as opposed to these older names, which a person who has an intrinsic minus thumb, if you call it a simian thumb, you might take that as an insult. The other point that he's making here, all the intrinsic muscles of the hand, including the fourth and fifth, the lumbricals, are ulnar nerve innervated. The only two intrinsic muscles that are median nerve innervated, besides the thenar eminence, are the lumbricals of 2 and 3, the second and third lumbricals. So that's an important point, distinguishing between median and ulnar nerve injuries, which we will talk about later. And now, Mugisha, I have a question to ask you. We have 10 minutes left. You want to continue with the video, which probably will not end because it's a longer video.
Maybe we can listen to questions.
You want to stop here and have questions? What would you like to do?
Maybe we can listen some questions and comments.
I'm sorry, I couldn't hear you.
I'm saying maybe we can listen to questions and comments.
Okay, very good. So we'll stop here.
Yeah, we stop here.
I'm just going to stop here, and we'll take any questions and comments before we close. I'm turning it over to you, Mugisha, to share this.
Yeah, good evening.
Good evening.
May I?
Please.
Okay, thanks. Professor, would you like to comment on paronychia, particularly the chronic one, in which sometimes we have to remove the nail? I would like to hear from you, especially acute and chronic paronychia and something related to that, please. Thanks.
I missed the question. Chronic what?
Paronychia, nail bed infection. Sides of the nail. Sometimes we get, while cutting the nail, it get infected. And the consequences may be osteomyelitis.
You're talking about a paronychia.
Yep, right, exactly.
Well, we're going to have a whole lecture on hand injury, on hand infections later on.
No.
But just
okay, perfect.
But just to say for now, simple paronychia you can often manage by hot soaks and antibiotics. On the other hand, for more advanced paronychia, they need to be drained, and sometimes either half or all of the nail bed needs to be, the nail, not the nail bed, the nail needs to be removed. It depends on the extent of the infection. And I'll just say that for now. We're going to have a whole lecture on hand injury, hand infections, including the treatment.
Thanks, Prof. Thank you.
Any other questions or comments? Thanks for that. Thanks for that question, because actually these anatomy lectures are focusing primarily on tendons, muscles, and nerves, but the anatomy of the nail bed is actually complex, and we will discuss that at length during the lecture on hand infections. Thanks for the question.
Yes, I've received none from the chat box.
Okay.
Yeah, but I think it is very pertinent. Every surgeon, every resident, every registrar in lifetime will encounter some hand problems or pathologies that will require an attention, and the anatomy that have been described is too profound. It started with superficial, then we went to deep, and till now we are having, when we're watching the videos, we can see from the cadaveric dissections, you see a lot of information that have been generated. So thank you very much.
Okay. So I would just say that when we give the regular course, when we're giving this in person, we actually do a dissection of the upper extremity. So if you are if you are a resident or a faculty member in a teaching program, maybe you can, a good way to really learn this stuff is to organize a dissection of the upper extremity, and then those of you who are taking this course, you can actually give the lecture. And you know, the only time you really know something is if you can teach it to somebody else. So if you have access to cadavers, and you can take an upper extremity, organize a dissection with a group of surgeons, and then you can actually go over these videos and then teach do the dissection and teach the people who are with you, and that way you'll really master it. Any other questions?
Eden, you're welcome. Unmute yourself, Eden. Eden Isa.
Yes. Can you hear me?
Yes, we
Yes.
can. Go ahead.
Yes, thank you for a good presentation, Professor. I had a question at what condition that you need to remove the flexor carpal channel. I mean the flexor retinaculum.
Okay, well, you usually don't remove the flexor retinaculum. Usually we are cutting the flexor retinaculum. And
yes.
we're gonna talk about the technique of doing that in a subsequent lecture. But you're opening up primarily for two reasons. Number one, if you're dealing with an advanced carpal tunnel syndrome. In other words, patient comes to you, they've got paresthesias, they have decreased sensation on the radial aspect of the fourth finger, the volar aspect of the third, second, and thumb, and actually even the median nerve innervates the skin distal to the PIP joint on the dorsum. So the skin over the middle phalanx and distal phalanx of the radial, the index and long fingers are median nerve innervated. So if you've got decreased sensation in that distribution, and or a pain at the wrist, and or weakness of the thenar eminence, those are indications to do a carpal tunnel release. And in doing that, we're going to talk about the technique of how to do it in subsequent lectures. You're going to just divide. You're not going to remove the flexor retinaculum. You're just going to divide it. And then the other indication, of course, is if you have what's called either a zone 3 injury, which is just distal to the flexor retinaculum, a zone 4 injury, which is through the flexor retinaculum, or a zone 5 injury, which is in the distal wrist, is proximal to the flexor retinaculum. You may have difficulty finding either the proximal or distal ends of the cut tendons, and in that case, you would divide the retinaculum, put some retractors in there, spread it open, and then you'll see the entire anatomy right in front of you. Remember, when you're doing that division of the flexor retinaculum, you must identify and preserve the median nerve before you make a cut in the flexor retinaculum, because more than one surgeon has cut the median nerve without taking sufficient care when dividing the flexor retinaculum, and then, of course, then you ended up having a ruined hand. Thanks for the question.
Thank you, Professor.
Last question, something that maybe we can allow it is, are there any variations in hand anatomy, as you have seen with other organs that you have experienced? That's number one. Number two,
Yep.
A patient a few weeks after involvement in car accident couldn't fully extend his thumb. Would it be injury to Abductor Pollicis longus or Extensor Pollicis Brevis?
let's do it the second question first. I missed what is the functional defect? Yeah, what's happening with the thumb?
Can't, he says, can't really can't fully extend his thumb.
He can't fully extend the thumb. Okay, so there are there are two thumb extensors. There's the extensor pollicis longus and the extensor pollicis brevis. Usually, if the extensor pollicis brevis is injured, you can still extend the thumb. So how you check this, if you look at my hand here, and you can see right here the extensor pollicis longus tendon. You can feel it in yourself if you extend the thumb. And then right below it, you can feel the extensor pollicis brevis. So if you can't feel that long tendon right there on thumb, when the guy's trying to extend his thumb, most likely the extensor pollicis longus tendon is cut. As I said, the extensor pollicis brevis is also a thumb extender, but it's a weak thumb extensor. So while it may be, sometimes you can cut both tendons, but if he can't extend the thumb at all, most likely you're dealing with a extensor pollicis longus tendon. Okay, so now I can now see the question. The other question is the abductor pollicis longus and the extensor pollicis brevis. Okay, so both those tendons, as we talked about, run through the first extensor compartment through the extensor retinaculum. The abductor pollicis longus primary function is stabilization of the thumb and abduction, like that. So if the patient cannot fully extend the thumb, most likely, I'd have to see the patient, of course, but most likely we're dealing with an extensor pollicis longus injury, not a injury of the abductor pollicis longus brevis or the extensor pollicis longus. There, as far I'm misspeaking of the abductor pollicis longus or the extensor pollicis brevis tendon. Remember, the abductor pollicis longus tendon is an extrinsic extensor tendon rising in the forearm, passing through the first extensor compartment and inserting on the first metacarpal. The abductor pollicis brevis tendon is one of the intrinsic muscles arising located in the thenar eminence, so it rises in the hand. And the abductor pollicis longus runs through the same extensor compartment as the abductor as the extensor pollicis brevis and the abductor pollicis longus are running through this first compartment. I don't know whether I've fully answered your question or not. The other question is, the question is, what type of accident did he have? Was there a cut there? Was there a fracture there? There are many other reasons why the thumb might not be mobile, particularly if it was a blunt injury. So if it was a car accident and there wasn't a cut there, then we're talking about possible ligament injuries or even a fracture, which could also interfere with the function of the thumb. So I don't know whether I think I've probably given you an inadequate answer to your question. But if there's no cut, most likely we're dealing with a ligament problem or a fracture problem. If there was a cut, most likely you're dealing with an extensor pollicis longus injury, because otherwise, because if that is intact, you should have pretty good thumb extension.
Yeah, he's saying the answer was satisfying.
Okay.
And the last one was about commonest variations of hand anatomy.
Oh, yeah. Well, of course, there are variations in hand anatomy, like there are variations in anatomy everywhere else. I've talked about the fact that sometimes, like in me, you don't have independent flexion of the superficialis of the fifth finger. For example, here, if I hold my, example, I'm holding my fourth finger out in extension, and you can see the only way I can flex my fifth finger is with the lumbrical, which is flexing the MCP joint, but I can't flex my PIP joint independently. The same thing goes with the profundus tendons. Usually, like here, like I have independent flexion of my index finger, which is normal, but some people have all four profundus tendons come off of one muscle rod. So some people are unable to do that, just like I can't independently flex my superficialis muscle. So those are just two examples. However, the basic anatomy that we talked about for the last hour and a half is pretty much standard in almost all people. And even if there's a minor variation, as long as you approach the problem, explore the injury based on these anatomic principles, you'll figure it out. So the variations are not that great, at least in my experience. Okay, Mugisha, back to you.
Well, thank you very much. I would like to extend my sincere gratitude to you for having taken us through a profound understanding of hand anatomy. Actually, it has been a very good reminder. And we know that the hand anatomy tend to go out of our memory quickly. So it was a very good reminder. I'm very thankful for your time. What are we doing next week?
All right, so next week we're going to, we will have a review with the video. We may watch the whole video again, or we may watch just the end of it that we didn't get to, I'll decide. But, you know, I think this anatomy is so complex that it wouldn't be bad to watch the video again. And then we'll talk, the lecture after that is how do you evaluate, how do you examine the hand and evaluate people with hand injuries? So we will, we're either going to do, we'll either do both of those lectures or just review hand anatomy again, because it's so critical. If you don't know the anatomy, you're going to have a tough time managing hand injuries. That's the bottom line.
Okay, thank you very much. I want to also thank the participants. This has been a Pan-African meeting, and we have received a lot of understanding. We have colleagues from Liberia, colleagues from Zambia, Malawi, Zimbabwe, and Kenya and Uganda. So it has been very wonderful. May you save the date that next Friday we are going to host again our Surgical Thursday. And we would like to have more people get involved. So shout out to your friends, and the link will be out soon. Otherwise, I would like to wish you a good evening and a good afternoon wherever you are. Thank you very much.
Thank you all very much, and have a wonderful evening. Bye-bye.
Bye.